A surgical airway or cricothyroidotomy should be performed in traumatically injured patients who are unable to be intubated either by oral or nasal tracheal approaches. If the patient's condition allows, take the time to don a sterile gown and gloves, surgically prepare and drape the patient's neck, and locally anesthetize the planned incision. The appropriate landmarks should be identified to include the thyroid notch, the cricothyroid membrane at the bottom of the thyroid cartilage, and the sternal notch. A skin incision is made over the cricothyroid membrane, which is then incised transversely, taking care not to damage the cricoids or thyroid cartilages. The incision in the membrane is enlarged by gently inserting a tracheal spreader, knife handle, or hemostat into the wound and spreading or rotating to open the airway. An appropriately sized, cuffed endotracheal or tracheostomy tube, usually a number 5 or 6, is inserted into the cricothyroid membrane incision, directing the tube distally into the trachea. Inflate the cuff and apply ventilation to the tube, watch for chest excursion, and auscultate the chest for evidence of adequate ventilation. Finally, secure the endotracheal or tracheostomy tube to the patient to prevent dislodging.